Hello everyone, myself Dr. Sheena. So today's topic for the discussion is access cavity preparation. So in this PPT, we'll be dealing with the various access cavity of each tooth and the individual anatomy of each tooth. So first of all, maxillary central incisor. Maxillary central incisor is actually a tooth with one root and also one root canal. As you can see in this image, it consists of one root and also one root canal. And the access cavity is having a shape of when we prepare an access cavity. So what is an access cavity? It is a opening that is created on the tooth surface to get access to the radicular portion or the root canals for proper cleaning and shaping and also obturation. So access cavity shape of maxillary central incisor is actually a triangular shape where the base of the tooth is towards the cingulum and the apex is towards actually the incisal edge. So this is actually the shape of the triangular shape is the shape of the access cavity. Another important thing that you need to know is the cervical cross section, the cross section of actually the root. It is like the apical cross section, the middle third cross section, and also the cervical cross section. You can see in this image the apical is almost round in shape, and the middle third it is oval in shape, and the cervical area it mimic this structure that is triangular in shape. So you can memorize it as ROT, R-O-T, that is round at the apical area, O at the middle third, and T at the cervical area. So always try to memorize this code and the image which helps you to answer properly. So talking about maxillary lateral incisor is a smaller form of maxillary central incisor. As you can see in this image, it is having a single root and also the single root canal system. So what happens is like whenever we prepare an access cavity, it is almost having similar to that of the triangular shape of maxillary central incisor, but it will be in a smaller shape, or in certain cases it might have an ovoid shape. So this is the access cavity shape or the opening of the tooth shape of a maxillary lateral incisor. Cross section is similar to that of the central incisor, round at the apical area, center oval RO. Instead of T triangular, sometimes it might change into ovoid. So first it was ROT, here it is ROO. Next is another question dealing. So palatal abscess are most frequently seen in. As you can see in this image, maxillary lateral incisor are the tooth with palatal or buccal curvature. So there is a chance of extrusion of the necrotic substance in the periapical area, and there is a chance of palatal abscess in maxillary lateral incisor. Very important. Talking about maxillary canine is again a tooth with single root and single root canal. As you can see in this image, it is having a single root and also single root canal, and as you can see it is the tooth with largest root length. And when we do access cavity preparation, it is having either ovoid, you need to study two important name, ovoid or slot shaped. Slot or ovoid is the name that is given for the access cavity for maxillary canines. And talking about the cross section of the root, it have again ROO, round shaped here. Here it is actually ovoid shape, and the cervical area it is again having ovoid shape. So this is similar to that of the maxillary lateral incisor, right? So talking about the access cavity in maxillary anterior tooth, how we do? First of all, we will actually start to find out the center of the teeth by actually drawing lines, and we'll start to penetrate the center of the tooth with the help of a fissured burr. Fissured burr is actually placed such that it is perpendicular to the anatomy of the tooth, and we will be placing about 1 mm into the tooth. After that, we will be changing the angulation such that the burr is changed to parallel to the long axis of the tooth. So we'll be changing the angulation of the tooth, and we'll be actually inserting the burr such that it reaches the pulp chamber. And once we reach the pulp chamber, you can see there is extra dentine present here which can obscure or stop in us attaining a straight line axis for cleaning and shaping. For that, what we do is like we use a round bar like this and we will remove the shoulder. This is called as a lingual dentinal shoulder. That is the excess that is present which might prevent the proper cleaning and shaping. So we will be removing that excess by a round bar, especially number 2 is used, and we'll be doing in up and down motion where the excess is removed, right? After that, you can see in this image we'll get a straight line axis where proper cleaning and shaping can be done. So this is the method how we create a nasal cavity preparation for an anterior tooth. Next is maxillary first premolar. This is a tooth where two root is actually seen, that is buccal root and palatal root, and the buccal root and palatal root contain one root canal. So it is the tooth with two root and also two root canal. So coming to the shape of the access cavity, you can see in order to include this tooth buccal and also palatal canal, we should prepare a cavity such that it is having a ovoid shape. So the access opening shape is ovoid in the case of a maxillary first premolar. So talking about the cross section of the root, all will be almost ovoid and round. It will be having ovoid, and the cervical area it is almost round, but ovoid, but in the cervical area, very important, when we take the cervical cross section, it will have either a elliptical or a kidney shape like this, which incorporate both the pulp chamber of the two root canal. So this is very important. There is a change in the cervical pattern when compared to the other tooth structure. It have an elliptical or kidney shape. Other all section like the middle third and cervical third is having round and ovoid root structure, right? Coming to maxillary second premolar, as you can see in this image, it is having single root canal system. Again, the cross section shows round ovoid in the cervical area. And the access cavity of this tooth is also almost ovoid in shape. It is almost having a ovoid shape of access cavity preparation, right? Talking about maxillary first molar, very important. This is a tooth with 3 root and 3 root canal. As you can see, the first root is the largest root, that is the palatal root, upper, and the most narrowest and the smallest root, that is mesiobuccal root, and the other root is actually the distobuccal root. So these are the three important roots of maxillary first molar: palatal, mesiobuccal and distobuccal. So the access cavity preparation shape in early times was like, you can see it is almost a triangular shape, and we got, this is the mesiobuccal, this is the distobuccal, and this is the palatal. So what happened is like, nowadays we started to observe a extra canal that is called as the MB2 canal. The MB2 canal is almost more mesially and more palatally placed. More mesially, and it is towards the palatal area. So it is more mesially and palatally placed, and it is named as MB2 canal. Right. So what we did was that from the triangular shaped access cavity, we actually changed in a slight trapezoidal shape, from which we actually got all the 4 canals, that is mesiobuccal, distobuccal, mesiobuccal MB1, MB2 and also the palatal canal. So these was the changes that we actually brought. Now, maxillary first molar consists of 3 root and 3 root canal, right? And in that, mesiobuccal is the narrowest root, as I said earlier, and it will show slight distal curvature. Very important, it shows slight distal curvature. And 35% of the cases, the fourth canal, that is the mesiobuccal, is in the palatal direction, right? Most of the cases, mesiobuccal is in actually the distal curvature, but 35% of the cases we can actually see it in actually the palatal direction. So how we prepare an access cavity? Access cavity, we know that there is something called as an oblique ridge, and most of the time all the canals are actually placed mesial to the oblique ridge. It is within this oblique ridge. So we will be drawing 2 line mesial boundary which connect the mesiobuccal cusp and also the palatal cusp, and the second is like the oblique ridge is there. so what we do is like we again choose the center. From the center we'll be actually penetrating into the canal, and we'll be moving such that we move the burr towards the palatal canal. That is because palatal canal is the largest canal and it can be easily accessed. So we'll be moving the burr towards the palatal aspect, and we'll be removing the pulp chamber from the palatal aspect, and after that it is moved into the mesiobuccal and also the distobuccal, where the roof of the pulp chamber etc. is actually removed. And as I said earlier, there will be certain extra dentine present, that is removed with the help of a round burr in an up and down motion. This is the extra dentine that is present, which will get removed, and it will actually provide a straight line access like this. Now you can see there is a palatal canal, mesiobuccal canal, distobuccal canal. There is a fourth canal, that is the MB2 canal. Understood? So very important thing, fourth canal is seen in the mesiobuccal root, and it is located more mesially, very important, more mesially and more palatally. So what is the percentage of the maxillary first molar having an extra root is like 84% of the teeth have a separate orifice, right? So mandibular, maxillary is more important, talking about the anatomy. Talking about the mandibular tooth, central incisor, almost all the tooth are having a ovoid nature and round nature of cross section. You can compare it and study with actually the maxillary tooth. And some important points that you need to memorize is, among single tooth, bifurcated root are commonly seen in mandibular first premolar. Because as I told earlier, mandibular first premolar, you can see in this here, mandibular first premolar, it is like this. It is almost having just a single tooth, a single root with single pulp chamber. But this is actually the tooth, mandibular first premolar is the tooth which can show maximum number of bifurcations like this, right? So the incidence of bifurcated root in mandibular teeth is mainly seen in mandibular first premolar, followed by mandibular canine and mandibular incisor. Very important. This is the main thing that you need to memorize when we study about the anatomy of the mandibular tooth. The incidence of tooth canal in mandibular incisor account for 25%, and it can be about 41% also, right? And maxillary canine and incisor are least likely to have bifurcated root. Hope I understood. These are the points that you have to keep in mind. As I said, in mandibular tooth, not much of an importance is actually seen till premolar. But what we need to study is like mandibular first premolar have two root followed by mandibular canine, mandibular incisor, the number has to be known, the percentage has to be known. Another important point, mandibular first premolar is called as enigma to endodontist. We have studied in the last PPT about Virtoussi's classification as well as Vane's classification. You can see it is not a single root canal. There are multiple root canal arising from a single root, right? Single root canal. So premolar is the tooth which showed all the 8 classes of Virtoussi's classification. That means that we need not think that it is mandibular first premolar, it will have single root, but it will have multiple challenges or multiple cross section can be actually seen in this mandibular first premolar. That is why the mandibular premolar is actually called as the enigma to endodontist. Never, it is a confusion to endodontist. Never think that it is single root. It might have actually multiple roots. Now, what is the access opening criteria for mandibular premolars? See, you can see the mandibular premolars in our mouth, it is having a tilt of 30 degree. Very important, it is having a tilt of 30 degree. Again, it have a buccal surface and also a lingual surface. So we have to penetrate such that it is not at the center. Since it is having a 30 degree tilt, it is halfway between the lingual, this is the lingual incline of actually the buccal. Halfway between the lingual incline, 1/3 the distance from the buccal incline, almost it comes here. The term is very important. Lingual incline, halfway between the lingual incline, this is the lingual incline, halfway between the lingual incline and 1/3 the buccal incline. This is actually the buccal cusp, just the 1/3. Half the lingual incline and 1/3 the buccal incline. There we start the access opening and we will get the straight line access. Understood? So mandibular premolar contain a tilt of 30 degree for compensating that and to avoid the like perforation. If we start from here, it will move like this and it will move to a perforation. That is why 1/3 from the lingual incline and half from the lingual incline and 1/3 from the buccal cusp. We need to do the access opening in the case of a premolar, lower premolar. So we have studied lot of points in mandibular premolar. Enigma to endodontist, 30 degree tilt. Access opening is, there is certain number that you need to memorize. Then what we studied, the important thing is like it is not single rooted tooth, it is bifurcated tooth, right? Next important anatomy, as we have studied in the case of a maxillary molar, mandibular molar is also important. Maxillary tooth, 3 root, 3 canal, extra 1 root gain, 4 canal. Here, mandibular first molar, 2 root, 3 canal. See, this is 1 root, this is another root. You might see a single distal canal, single distal root like this, distal. But here, it contains 2. Mesiobuccal, mesiolingual, like this. Now, this is actually the anatomy of the pulp chamber. Mesiobuccal, mesiolingual, and distal, right? So, this is actually the anatomy of the mandibular first molar. It consists of mesiobuccal, mesiolingual, and distal. Now, what happens is like, the access cavity shape is almost triangular in shape. See, you can see it is actually almost triangular in shape like this. So, sometimes there is a fourth canal called distal gets split into distobuccal and distolingual. You can see this is distobuccal and also distolingual, which give them a trapezoid occlusal cavity. So, 2 root, 3 canal, distal, mesiobuccal, mesiolingual. When we take the cross section, it will have triangular shape. Sometimes the distal split into 2 canal, distobuccal, distolingual, forming a trapezoidal in shape cavity. So that is an important thing that you need to know in mandibular first molar. Next is like the mesiobuccal orifice comes under, this is the mesiobuccal cusp. It comes under the mesiobuccal, center of the mesiobuccal cusp. Second, mesiolingual orifice comes under the, here is the central groove. It almost comes under the central groove. So mesiobuccal cusp ka center mesiobuccal orifice comes. Central groove comes the orifice of the mesiolingual orifice, and the distal orifice is having a elliptical shape and usually present at the center of the mesiobuccal. Here it is almost present at the center, right? And 30% of the lower first molar show 2 distal canal. All these values has to be memorized. 30% 2 canal. Upper tooth, 84% of the tooth shows what? 2 canal in the mesiobuccal aspect, right? So that was all about the access cavity preparation. Main important thing that you need to actually memorize while you do an access cavity preparation in maxillary molars, mandibular molars, mandibular premolars, and anterior tooth. Next is how to locate canal. There are certain points that you need to keep in mind. First is fast break route. Now, what is fast break route? See this image. You might think that this is actually a calcification. No, this is called as fast break route. Fast means there is sudden break in the canal which we see. See, there is sudden break. Nothing we can see here. This suggests that there is present of another root. Because of the 2 root coming and showing it in the radiograph, we are not able to see the canal. This is called as fast break rule. So fast break rule always indicate in a radiograph there is a present of an extra canal. Next is champagne bubble test. Champagne bubble test is like we will be placing the hypochlorite within the cavity like this, and where there is an extra canal, what happens is like the sodium hypochlorite consists of hypochlorite that comes and act on the organic part of the pulp, and there are small bubbles formed. So when we see into the cavity, there are small bubbles coming out that indicate that there is an extra canal seen, right? So one question is like, what is the primary function of access opening? The primary function primary function is always providing a straight line access to the apex. Another important thing that you need to know is the law of pulp chamber anatomy. So, how to find out the canal? As we have already studied, there is fast break rule, that is Champagne bubble test is there. Similarly, certain laws are there which helps to find out the canal. It was given by Krasner and Rango. He said that cemento enamel junction, that is near to the cervical area, is the most important thing in finding the root canal. First is law of centrality. He said that always the canal is located at the center of the teeth at the level of CEJ. Very important. Next is law of concentricity. The walls of the pulp chamber, this is the pulp chamber, the walls of the pulp chamber are concentric to that of the external surface. That means that the shape of the pulp chamber is similar to that of the shape of the outside surface, right? Law of CEJ means the distance from the external surface to the root to the pulp chamber is equal in all the aspects. Next is law of symmetry. You can see in this image, when we draw a line crossing through the mesiodistal direction, the canal which we get are equally placed from the mesiodistal direction. That is very important. Equidistantly placed. Second, law of symmetry. It states that except for maxillary canal orifice, it perpendicular to a line, it always lie, the other was equidistant, the distance is equal. Here it is lying in a line that is perpendicular to the long axis, perpendicular to the mesiodistal line. Now there is something called as law of color change. Whenever we see the pulp chamber, you can see it is more darker when compared to the dentine around. So we will able to assess a canal when there is change in the color. First law of orifice location. It suggests that the orifice of the root canal are at the law of, so this is like a wall, this is like a floor, and this is like a wall. So it is at the junction here where we see the root orifices, right? Second is like it is at the junction of the floor wall junction is the second law of orifice location. And third is like we can see certain developmental grooves. This is the developmental grooves. It is at the terminus or the end of the developmental grooves where we can see the root canal. So this was actually the laws that was given by Krasner and Rango, which helped to find out the canal at the level of CEJ. So hope you understand all the concepts in root canal anatomy, individual tooth anatomy as well as the access cavity. So in this, you need to know, not study everything in NEET PG preparation, just study the maxillary, upper molar, lower molar, premolar, and the numbers which have more of a chance of root, lower, upper, all those numbers, and the method to find out the root canal. Hope you had a nice class. Thank you. We'll see you on the next class. Thank you.